Why do so many orthodontic cases relapse? What is the cause of malocclusion, irregular teeth, misshapen jaws? My name is John Flutter, and I'm a dentist.
I've been a general dentist for nearly 30 years. For most of that time, orthodontics has been an important part of my practice. Today, over half my workload is orthodontic treatment for children and adults. For the first 15 years, I treated orthodontic patients very much as I was taught as a dental student. That was by removing teeth in those children with crowding, and then moving the remaining teeth with removable appliances.
I then briefly stopped doing orthodontics.
Why? Because I was not happy with the teeth, the facial appearance, or the long-term stability of the results I was achieving. I will show you what I mean.
I started asking myself, why is it so many orthodontic cases relapse? Is there a cause of malocclusion that I am not addressing? Why are some faces damaged during treatment?
This DVD is about what I have learned in the last 30 years. If I see a patient in my general practice of, say, 35 years of age, and they have straight teeth and a good occlusion, I always ask, have you ever had orthodontic treatment? What is the answer? Almost without exception, the answer is no. On the other hand, if I see a patient of the same age with irregular teeth, and I ask the same question, then I may get the answer yes or no. I see a lot of adults with crooked teeth, some with extracted premolars, some without.
I have attended lectures and taken courses in orthodontics in Australia, the United States, and in Europe. I have seen, learned, and used many different orthodontic techniques. I have good records of all of these techniques applied in my general practice over the last 17 years. I've played a large part in the development of interest in dentofacial orthopedics in Australia.
I now have over 2,000 finished cases with comprehensive records using a variety of techniques. I have used those records to look very closely at what was achieved. At the end of every course of treatment, I review the case with the child and parents. I display before and after records and evaluate the results. If I keep looking long enough, most cases relapse to some extent. A few need retreatment. I will give you my thoughts on that. About 20 years ago, shortly after my father died, my mother gave me £1,000 from his estate. 2 days later, I was in Hong Kong looking at cameras. I blew it all on a camera and dedicated 200mm medical lens with ring flash, and I've been taking pictures of much of my dentistry ever since. The still photographs tell us a lot about what is changing in the hard tissues. A digital video camera enabled me to record the changes that occur in the dynamic, moving world of soft tissues and posture. I have been looking in that area where most orthodontic interest stops.
I've been focusing treatment on the importance of establishing nasal breathing, creating a good lip seal, and changing downward growth into forward growth in the growing child. When I succeed, facial appearance improves.
I have been studying and working with chiropractors to identify and manage the relationship between posture and malocclusion. I have been studying the cranium, the cervical spine, breathing patterns and posture of both the body and posture of the jaws.
Some of my ideas may be new to you, but much of the material has been documented for years. Other health workers have a lot to teach us dentists about an area that we've considered our own for over a century.
Recently, I have been taking video images of patients before, during, and after orthodontic treatment. This reveals the dynamic, moving nature of the jaws, the muscles around the mouth, and the head posture. It also demonstrates that the teeth, head, and jaws are an integrated part of a body. I have been looking beyond the teeth for a solution to the problem of long-term dental stability. I show you how I integrate these things into daily practice.
In 1995, I was asked to present at the first Dentofacial Symposium in Sydney. I had almost no slides, but thousands of photographs. I made many mistakes on the steep curve learning how to present my photographs. It was my brother-in-law who suggested I used a computer and a data projector. From persuasion to PowerPoint, I've been exploring multimedia presentations for 7 years. It enables me to demonstrate the moving, dynamic nature of the structures that we're dealing with by using moving images.
The emphasis of much of the training and treatment of orthodontic problems focuses on the tooth and jaw position. For many clinicians and teachers, a large part of diagnosis, treatment and evaluation is determined by carefully traced cephalometric X-rays and accurate measurements of plaster models of the jaws. For many years, facial appearance has played as large a part as cephalometrics in evaluating change. More recently, the functional and postural changes appear to me to be the most important of all. Increasingly, training and teaching is focusing on facial appearance. I am trying to add to the understanding of facial appearance, function and posture. Patterns emerge when I evaluate and analyze models and cephalometrics in conjunction with changes in appearance, function and posture. My conclusion is that tooth and jaw position, the form, are a result of and integrated with function and posture. What do I mean by form, function and posture? This program is intended to demonstrate what I have learnt by that. Today, when I see a patient in my practice for the first time seeking orthodontic treatment, I watch them while they are talking, swallowing, breathing. I look at their body posture. Why do I do that before I look in the mouth? Well, almost without exception, when I have studied those things, I know what the teeth are going to look like before I look in the mouth. With passing time, I have become more accurate.
I've included a large section in this program to demonstrate that. I call it Soft Tissue Dysfunction Analysis. You can use it to see how different soft tissue patterns result in different malocclusions. It is not difficult to see. It is easy to record with video. I show you how I document it. It is very difficult to measure.
Before we start and after we finish orthodontic treatment, we need to evaluate soft tissues. I hope this section makes that easier. Orthodontists have recognized the relationship between soft tissue function and malocclusion since orthodontics started. The challenge is trying to modify soft tissue patterns in our patients. Changing muscle patterns requires a lot of time devoted to it. I've tried to do this in a number of different ways without much success. In recent years, I have had a lot of success in modifying muscle function using some appliances called trainers. I have included sections on trainers showing how they work and the changes I have seen as a result of using them.
This program has been designed to be used by dental professionals, so I have used dental terms throughout the presentation.
I have presented this material in 28 countries. I present a one-day program, The Myofunctional Influences on Facial Growth and the Dentition. Most of the material I use in those presentations is included here in the same order. I have included a section on my courses.
Finally, I have studied with some very able clinicians and academics. Some of them have far greater clinical skill than me, so I have used their material on occasion and identified it. In my practice, I get a range of results. Some children growing and developing very well, and some with years of treatment and almost no change in growth patterns. I share them all. We have much to learn. I pose many questions as well as offering some answers.